Good afternoon, ladies and gentlemen. I would like to welcome you to the second industrial symposium of today. So hope you are happy with the meals and not too sleepy to listen to this session. So this symposium is entitled TB-HIV, Why IGRA Screening for LTBI in People Living with HIV is Critical to Ending this Deadly Syndemic. And this is sponsored by Biomed Diagnostic and Oxford Immunotec. Let me introduce the speakers for these sessions. So the first speaker is myself. I'm going to be a moderator too. So my name is Thana Khawcharoenporn. I'm the Associate Professor of Medicine from Infectious Disease Unit, Faculty of Medicine, Thammasat University, Pathum Thani, Thailand. And the second speaker is Dr. Jakapong Bominhen. He's an Associate Professor of Medicine from Division of Infectious Disease, Faculty of Medicine, Ramathibodi Hospital, Mahidol University, Bangkok, Thailand. So in the first part will be my talk. So this is my disclosure. The all I'm going to talk about today is going to be introductions, and then LTBI in people living with HIV, diagnosis of LTBI, and we close up with the relevant studies and guidelines. So let's start with introductions. You look at the latest data from WHO, you can see that the number of TB cases, so the left side is the number in million per year, and on the right pictures is the number in rates per 100,000 population per year. You can see that the numbers seems to be stable on the top line here, and maybe a little bit up in the past couple of years. And this is due to that there's notifications of new and elapsed cases. However, if you look at the number of HIV-positive TB cases for the past 20 years has been decreased significantly. Nonetheless, for example, in Thailand, when we look at the data, when you look at the incidence of tuberculosis per 100,000 population, you can see that the incidence in people living with HIV is about 20 times higher than the incidence of TB in general population. So HIV is still a major risk for tuberculosis. And TB and HIV has some interaction that should be noted of. So tuberculosis can cause rapid progression to AIDS and death among people living with HIV. And as you know that the treatment, both using anti-TB drugs and antiretroviral therapy, can cause significant adverse reactions, and they can be synergist. And at the same time, there could be a drug-drug interactions between anti-TB and the antiretroviral therapy. For example, dolutegravir and rifampicin. On the other hand, HIV itself can increase the risk of tuberculosis, can cause more rapid progressions of tuberculosis, and the people living with it seem to have more severe tuberculosis than general populations, seem to have more relapse and recurrence. And the mycobacterium tuberculosis that's called TB in HIV patients seem to have more drug resistance. So the World Health Organization has proposed a global plan and strategies to end TB by the year 2030. This is a holistic, multi-sectoral response to overcome the issue and challenges faced by many countries and to help each other to end the epidemic. So basically the main message is that we cannot only just passive approach to diagnose and treat active disease. We also have to actively find the case of LTBI and treat them appropriately. Otherwise, we're not going to reach the goal of NTB by 2030. So what to do? So the WHO recommends that the country had to scale up the joint tuberculosis and HIV interventions, and also manage the comorbidities that can increase risk for acquiring Mycobacterium tuberculosis infection. At the same time, the country should implement the integrated TB-HIV service model and interventions that everyone in the country can access. For example, they have to have the HIV testing and counseling for all presumptive and diagnosed TB patients. So everyone who has tuberculosis needs to have HIV testing. The second one is we have to have systematic screening for people living with HIV, screening for tuberculosis, which we're going to talk about more in the later slides. The third one is that the country should provide an ART and adequate preventive therapies. And then also provisions of prophylactic TB treatment for people living with HIV. And the last is to effective management of comorbidities that can increase risk for tuberculosis, such as diabetes, hepatitis, silicosis, and others. Now let's talk about LTBI in people living with HIV. So LTBI, or latent tuberculosis infection, is a form of asymptomatic infections caused by Mycobacterium tuberculosis. And to diagnose that, you have to prove that that person does not have any evidence of active TB that could be elicited by the history, no fever, no night sweat, no weight loss, no chronic cough, by the physical examinations, no abnormal lung findings, skin lesions, or lymphadenopathies, no abnormal labs, or any imaging studies suggesting of having active tuberculosis. Why LTBI is important? Because it increased risk of subsequent active TB development, and it's very, very high in people living with HIV, 10% per year risk, compared to 10% in the lifetime in non-HIV individual. And the study said it's considered about 15 times higher risk for developing TB if they have latent tuberculosis infections. And the specific group of populations that have the highest risk is among those that have CD4 less than 200 cells per cubic meter in the endemic settings, and especially within the first 2 years of acquisitions of Mycobacterium tuberculosis, because at that time, the risk of developing active TB is the highest. So there are ways to reduce the risk or prevent progressions of latent tuberculosis to active disease. So the two major ways. The first one is providing or prescribing antiretroviral therapy. And the second one is consider treatment of LTBI, or we can call it TB prophylaxis. So there's evidence to support the LTBI treatment in HIV. So I show you here the systemic review that involved 12 RCTs involving 8,578 people living with HIV. And this study was conducted in both developed and developing countries like Haiti, Uganda, Kenya, Zambia, South Africa, Spain, USA, Mexico, and Brazil. So the main results show that the treatment of LTBI, so this study, they mainly used just INH monotherapy, can decrease the risk of TB disease by 62% and decrease the risk of death by 26% among the participants who had TST reactivity, or tuberculin skin test reactivity. But there's no significant benefits among TST non-reactive participants. Also, we have to look at what efficacies that either isoniazid prophylaxis or ART contribute to the prevention of active TB. So these three studies show that among the participants who received combinations of ART and IPT, or isoniazid preventive therapy, has the highest efficacy in preventing TB compared to if receiving either IPT or ART alone. So conclusion is that ART is not enough. You just prescribe ART alone is not going to increase the efficacy enough to prevent tuberculosis. We also need to provide a TB preventive therapy as well. However, to reach the goal, to prescribe the prophylaxis therapy to the right patient, we need to make a correct diagnosis first. So now talk about LTBI diagnosis. So the currently available tests for diagnosing of LTBIs, there's two tests. The first one is tuberculin skin test, or TST, and the second one is the interferon gamma release assay, or IGRAS. So the individual have to have these test positivity plus no evidence of active TB before we can make diagnosis of LTBI. So let's talk about tuberculin skin test first. So this test used the delayed type hypersensitivity response, or type 4 response, that's been mediated by the T lymphocyte. And the tuberculin solution that has been used worldwide, the first type is PPD, or purified protein derivatives. We use 5 tuberculin units, or 0.1 milliliters. Or the second type is RT23s, that we use 2 tuberculin units. And we have to use the Moton techniques, which is intradermal injections of the tuberculin material on the inner arm of the inner surface of the forearm. However, the result needs to be read and interpreted 48 to 72 hours later. So the cutoff that was recommended by the US CDC is at least 5 millimeters for reactivities. So what are the pros and cons of this test? So the pros are TST is cheaper, a cheaper test. It has a long experience of use as an initial testing, or to figure it out whether individuals has a test conversion or not, so serial testing. They be more available in many countries in the world, and especially in Thailand, the TST is considered on the Thai National Essential Drug List. That means everyone can access it for free. But the cons, there's a lot of cons though for TST. The first one is the false reactivities that can caused by recent BCG vaccination, the co-infection with NTM infection, especially the Mycobacterium avium complex, or MAC. The second one is the false negativity that can be filed for severe immunosuppressed persons, or the person who recently received MMR vaccination. Also, if you ever administer this test, you can see that there could be an errors during an administration process. Sorry, whether you can do like real or true intradermal injection, or it may be subcutaneous or intramuscular injection instead. And there could be errors for interpretation. So we have to measure the induration, not the redness, not the flare, not the erythema area. Yeah. And the last one, which is a very important limitation, is that it requires 2 visits. So sometimes we lost the patients to come back again for reading and interpretation. There are also other considerations for this test among people living with HIV. So if the test was done when that person has CD4 less than 200, it has to be retested when the CD4 come up more than 200, because initial results can be falsely negative. And cutoff of at least 5 millimeters reactivity in Thailand, I think may not appropriate. Because there's one study I'm going to talk about later that made the cutoff of at least 10 millimeters for reactivity is maybe more appropriate to use. And annual testing for TST is recommended only for the people living with HIV who have history of negative tests at first, and then subsequently they have a higher risk of repeated or ongoing exposure to people with active TB. So now talk about interferon gamma release assay, or IGRAS. This is an in vitro blood test that uses a cell-mediated immune response. Pretty much we measure the T cell interferon gamma level that was released by the T cells following the stimulations by tuberculosis antigens, the specific antigens. 2 types of IGRAS are available nowadays. The first one is enzyme-linked immunosorbent assay, or ELISA-based whole blood test. And the second one is this enzyme-linked immunospot assay that was performed on separate and counted peripheral blood mononuclear cells. And we count the spot. So the pros for IGRA, the study showed that it has high sensitivity compared to TST. because it has less effects, less impact from low immunity. Also has higher specificity than TST because there are no effects from BCG vaccination, and has less effect or less impact on the cold NTM infections. And how to interpret the result, be more objective, reading the level or counting the spots, and require only one visit for the test. But the cons, absolutely, the higher cost, and it may have limited availability in all other countries. And in terms of experience on use, it's kind of less than TST, especially for serial testing. So the last section I'm going to talk about is about relevant studies and guidelines for LTBI diagnosis. So this is a study that we've done in Thailand. The first study was done almost 20 years ago that involved the people living with HIV with CD4 median about 139, so low CD4 count as initial enrollment. And you can see that we've done a TST and the prevalent or the positivity, the reactivity rate is 37%, which is pretty high. And then the second study, we did it again about 10 years ago, but we did it in the people who have a higher median CD4 count, and did simultaneous two tests. And you can see that the rate of reactivity in TST is still higher, 16% compared to IGRA positivity, 12%. From this study two's finding, we found that there's low level of agreement between TST and IGRA with a kappa level of 0.26, and we found that long-term smoking was the independent risk factors associated with TST reactivities. So we postulate that maybe smoking was a reported risk for asymptomatic acquisition of MTM infection, so that can cause false positivities of TST. Now, in that study, we used IGRA as a standard test and compared the performance of TST to IGRA. We found that TST has a false reactive rate of 12%, and the independent associated factors was long-term smoking. And the false negative rate of TST is 60%. It's associated with age more than 52 years and female sex. So we'll be plotting the kappa level with the skin reaction size of tuberculin skin test as a cutoff. We found that the best kappa level, the best correlation result with the IGRA, we have to use the cutoff of at least 10 millimeters for reactivities. In another study that we've done in Thailand too, we evaluate the utility of IGRA as initial test and serial test. So this is a 4-year prospective studies conducted in 150 Thai people living with HIV, and all the participants underwent simultaneous TST and IGRA at care entry. So we can divide the participant into 4 groups based on the test result. The first group with positive both tests, the second group positive only IGRA, the third group positive only TST, and the fourth group negative for both tests. And we look for the primary outcome, the 3-year incidence of active TB. So we found that only the group 2 that has IGRA positivity has the highest 3 years incidence of active TB, and significantly more than the other 3 groups. Why there's no difference in terms of HIV outcome over time between the 4 groups in terms of retention in care and receipt of ART, CD4 chains, or virologic suppression. So that means that IGRA may be a good test that can identify at-risk patients when we follow up for 3 years. And also we look for using IGRA as a serial test. And I have to say that this is a small sample size. We perform, so that's 19 people living with HIV who have initial positive IGRA in this study, and we follow the IGRA level among them at 1 and 2 years after. So 16 of 19 complete IPT, 9-month IPT, and they all have significant decrease in interferon gamma level. Among the 16, 69% has test reversion, meaning positive to negative tests at 1 year, and 12% of them had reversion at 2 years. However, there's 19% of participants did not have any reversion during the study period. And also 3 participants who declined IPT at first did not have reversion. So as a summary for these studies, the initial IGRA guided IPT was effective in preventing tuberculosis because it has a good sensitivities. However, the serial IGRA for evaluating IPT effectiveness had limitation due to the delay in reversion, the lack of reversion, and lastly, especially in those with high baseline IGRA level. It is really hard that the level will come down at 1 or 2 years to have reversion. So in terms of guidelines for LTBI diagnosis in people living with HIV, so the US guideline recommend that both TST and the approved IGRA are considered appropriate for TB screening, and the decision how to interpret the results, whether IGRA or TST, should be based on medical public health management and should include a history of the patient's epidemiological data and clinical information to interpret the result. The WHO guideline also suggests that either TST or IGRA can be used for screening LTBI, but the WHO kind of more an aggressive approach that sometimes some of the group of population do not require LTBI testing before providing preventive therapy, such as people living with HIV and a child of household contact aged less than 5 years. For Thai guidelines, we also suggest that either TST or IGRA can be used for TBI testing, and is not required, especially in the new case with ART less than 6 months and CD4 less than 200, because this group of population has a high risk of LTBI and developing active TB later. So you can just prescribe preventive therapy without the need to test, and also same at the WHO, the close contact. So in summary, diagnosis and treatment of LTBI in people living with HIV are critical to active disease prevention and the success of ending TB by the year 2030 as proposed by the WHO. Either TST or IGRA can be used for diagnosis of LTBI among people living with HIV, but you have to take into considerations in terms of patient history, physical examination, investigation, and local epidemiology. IGRA may have better performance in terms of sensitivity and specificity than TST, and also because of the limitation of the TST, we have to think about that too when performing the test on the patients. And lastly, extending data on the utility of serial IGRAs for diagnosing new LTBI or follow-up for the effectiveness of preventive therapy are currently limited. So I think that is for my talk, and I will keep this Q&A session to after this, the second speaker's talk.